Thank you very much, Professor Dacre, for that kind introduction. Distinguished teachers, ladies and gentlemen, and all the students at the back. When I did this lecture, I thought it's not applicable too much to Sri Lanka, and I said definitely it's a bit out of place in Jaffna. But after hearing the last speaker's last two slides, I think world over it's a similar situation when it comes to the medical students, and I think it might be well worthwhile talking about this. The timer is on.
It is shown here.
Good, thanks. I like to talk, so I had to moderate my talk with the timer. Let me start with a quote from William Osler. You can read any literature from 100 years ago or as of last year. It always starts with the quote of, to study the disease, phenomena of disease without books is to sail an uncharted sea, but to study thus without patience is not to go to sea at all. How true. There are few things which stand the test of time, and this does stand the test of time. And I like the last one even further. He really wanted what's to be written on his epitaph was, he said, tell everyone I taught medical students at the bedside. I would like someone to write that for me as well. So why is bedside teaching important even today? Because whether you are in the USA with your competencies, or whether you are in the UK with your skill sets, or whether you are in Australia with their curricula, this is one clinical setting where the entire spectrum of the curricula can be taught. There is no other place to teach medical interviewing to your trainees. And like children, if you are good at it, they are good. If you are really bad at it, they get bad. But like children, they learn the bad things fast, but they're not too good to learn the good things. So you need to do it even more and more. What better place is there to demonstrate physical examination techniques? There is no time. World over, I hear the same talk, there's no time. There's no time in the United States, there's no time in the UK, there's even no time in Jaffna. And that's a fact of life. So we can't demonstrate the entire physical examination from head to toe. Those days are gone. So what you can demonstrate is a capture of a system, or even one part of a system at the bedside. And you'll be so shocked that if you ask someone to tell the 6 qualities of a pulse, no one knows. It is VSS, vital signs are stable. I thought it was Virgin Atlantic. What better place than demonstrate interpersonal communication skills? It's at the bedside. And you will be surprised that even in the United States, when it comes to people suing you, even if you're a bad doctor and do a bad thing, but you're a good guy at the bedside and you chat very well, the chances of you getting sued are much less. And that applies all over. What better place to teach how humanistic you are and how your professional traits are, how angry you get or how calm you are, than at the bedside. And this part of it, I find it a bit difficult even now, because sometimes you do get angry and it's so hard to control it, but that's something you all should learn, and I should learn, and we all should learn. It's no more a one-man show. It's always a team, and what better place than to develop and demonstrate a teamwork, working with nurses and pharmacists and others. Clinical diagnostic reasoning is a very important thing, even in this technological world we live in, because sometimes we can do all the tests, but never find the answer. So what better place to teach clinical diagnostic reasoning with the real patient, with the real problem, and then you are trying to solve it in your mind, and your trainees who are junior to you are watching it. This is a place, over time, you and I have learned illness scripts. And this is a place the trainee thinks, oh, he's a magician, he just pulled this diagnosis out of his pocket. No. It's just a repetitive seeing of patients and developing illness scripts which made us like this. And if we do not transfer that skill to our juniors, we have a problem because me and my colleagues have reached a stage, we might have to go to hospital. And we really want someone who can think and treat us, and we know that we don't do it most of the time. It's a really frightening experience when you or your family member is in a hospital. And I'm sure most of us have gone through it, and I have gone through it quite a bit. And that's the motivation for bedside teaching. What better place to develop analytical reasoning, and there is no better place to recognize pattern recognition. Some disease diagnoses are just a pattern recognition. You don't need to waste time. So the clinical teachers, no wonder they're overworked and frustrated and exhausted because they have to do two things. They have to diagnose the patient's problem, and they have to diagnose the learner's ability, skill, and learning. So actually they're doing two jobs in a ward round than if you're just doing, let's say, a non-teaching setting, you are seeing patients. And that is the place where we put in knowledge, context, experience. And the students and trainees and registrars now, they give you a lot of information, really. I mean, they become quite verbal, and they're very smooth talk. They're carrying the iPhone. They pick some things there. They give you a whole heap of information, but they don't have a commitment to a diagnosis, nor can they put things together. So this bedside is a place where you take the story, and of course you're bombarded with data from the computer labs and your scans, but you have to represent the problem to the trainee in a way that it makes sense, and that skill is best learned at the bedside. Because if you do not generate a single or at least a 2 or 3 differential diagnoses, I mean, you can keep chasing the whole year to find a diagnosis. I'll skip that. So another theory is students hate going near patients and doing bedside learning. That's absolutely not true. And I learned the last 4 years in Australia that it's not true. You take the students to the bedside and teach, and in Australia, when most of the interns and registrars, the junior house officers, are sent out to the country where there's no one else. So they keep writing back and saying, thank you very much for taking us to the bedside because we feel so comfortable all by ourselves. So students like it, but you got to do it so that you make them like it. Just some statistics. In 1960, it was 75% was bedside teaching. In 1980s, it was 16%. Currently, the literature says from 4 to 19%, but I think an accurate estimate would be less than 10% in the best of hands. We'll come back to that, why that is so. But I think teaching on the ward round in our time was on the fly because our clinicians were so experienced that they could change any setting into a teaching opportunity, and they could do it very, very well. But that generation has passed on, and the current generation, we are not too bad, and the next generation is not good at all. So I think we need to make a deliberate and planned approach to bedside teaching to make it really effective. So in my job plan, and we got a job plan in Queensland as well, it was no plan, but the new government is cracking the whip. So in my job plan, I have at least 5 hours of bedside ward round, and my post-take round starts from 8:30 to 11:30 on a Thursday morning. And even if I'm not on call, there is a post-take round. I like to call it GTWR, the Grand Teaching Ward Round. And I make my plan very clear that everyone knows. We have multiple learners in the team, so I just have some idea what level they are. I'm very optimistic about the time constraint, but don't get carried away. If there are more patients, I'll limit the topics. If there are less patients, I can expand. I have a set of objectives for each trainee, and each one of them is mastering atrial fibrillation. So whether you are a medical student, whether you're an intern or you're a registrar, once you finish with me from 4 to 10 weeks, you should be a master in atrial fibrillation, because I don't know about you all, atrial fibrillation seems to be the major issue in the world now. You don't have to do all the teaching. You have senior registrars, so you can target some teaching to them, and you need to know how you can help the students, those people who sort of fall off the radar and just keep at the back. Bedside rounds can be deceptively difficult. So people who do not do it regularly, the junior consultants, who might feel that they are feeling a bit uncomfortable taking history, so they avoid it and it becomes a vicious cycle. But if you know to say, I don't know in front of your trainees, things get much easier. It's moving more towards outpatient bedside teaching, but I'm going to skip a couple of slides. I like the 1-minute preceptor model for outpatient teaching. The resident or the student presents you briefly the history, and I ask them, what is it? Just one diagnosis. The trainees like to give a lot of information, but they don't want to give you a commitment. It is angina. No, they say chest pain, it could be ACS, it could be STEMI, I don't have the troponin. So and then you probe for supporting evidence. You teach a general principle crisp in three lines. Reinforce what the trainee did well. Correct any mistake. Give a page to read on that patient, and you move on. Because the clinics are very busy, and now it's about productivity and activity. So when the activity and productivity gets too much, something got to give way. I wanted to crack a joke, but I think I'll skip that. If it's all so good, if it's all so good about bedside teaching, why is it going down and down? The two major players in this. The one is the explosion of technology. I moved out of here in 1992. There was a one-slide CAT scan, and if I had to do abdominal CAT scan, I had to sit in the CAT scan room for 2 hours. I never did a CAT scan. But now we have a 328 CAT scan. You just come in and you come out in 1 minute and you have been scanned. So the explosion of technology has instilled in our kids and the trainees a technology tenesmus thinking it's going to solve the problem. Number two, there's pressure on the health budget. That's because we did too many tests. And now it's come a vicious cycle that we have to see more patients, do more things, discharge more, and show that you are working for your money. The third thing was that trainee hour restrictions brought in a shift mentality, and they forgot that there is a continuity care, and it's just that, let me come in, let me write it, let me go, he can figure it out. Business people running hospitals is not very good. So Abraham Burgess, if you haven't listened to his TED talk on bedside teaching and things, it's a good thing. So he wrote in the New England Journal of Medicine that patients have become eye patients, especially when you have electronic record. They are on the computer screen. We are in the bunkers. We are knocking out computers. We are ordering tests. The patients were peeping out of his room to see whether someone's going to come today at least. And it goes on, but not being at the bedside, we miss simple things which can stop this diagnostic testing, the chain reaction. So there are 3 eras, which they were the high-touch eras of taking history, bedside, exam, minimal in investigation. Then moved on to the lab-centered era, and then going behind the doctor and see whether, are you okay, you're working too much, don't work too much. All put together has caused this demise and decline of bedside teaching. What can we do? We can't stop the decay, but at least we should prevent the progression. We need teachers who can still emphasize the values of bedside teaching. Far and few, but catch them, use them, don't lose them. Teachers who recognize our job is to educate the next generation of doctors who will take care of us. Our job is not to placate them. Examinations with emphasize clinical skills and not move on if you are not good. So all this problem has caused this new disease called hyposcalia, which is a deficiency of clinical skills. You spend scant time with patients. We are quick to treat everyone. We know nothing about the natural history. We don't care because I'm off at 4 o'clock. We are proficient at ordering indiscriminate tests, but we don't know anything about his interpretation or indication, but we are good at the numbers game. The troponin is 1, got to do an angiogram. The troponin is 0, he's got to go home. So ladies and gentlemen, the bedside medicine, I'm a cardiologist. I get a little bored with echoes now, but what keeps me ticking is my GTWR every day. Thank you very much.